As orthopedic surgeons, we manage osteoporosis and its complications. This morning, we're going to talk about an aspect of osteoporosis management that orthopedic surgeons hardly talk about, and that is the use of calcium and vitamin D, which often we just take for granted. What are the indications? When do you use one? When do you use both? Or when is it time to use neither of them? Now, there's so much fake news circulating and things about complications, etc., scare our patients. So it's important for us to know what the truth is. To start with the case, this patient, my patient, is an 89-year-old female with back pain. She has on and off symptoms of this, which was aggravated particularly during the pandemic when she had to stay home. She has no history of previous falls or injury. She is a widow, but she lives with her daughter and her family, and her lifestyle is mostly sedentary. She has hypertension, but she has no diabetes, thyroid disease, or apparently no serious medical illness. She's a home ambulator, but there is a note that she might be frail. She has an evident Dowager's hump. Obviously, your diagnosis would be postmenopausal osteoporosis. So how do we proceed? What tests do we do? Serum calcium? Which one? Total or ionized? Vitamin D blood levels? Serum creatinine? Do we have to take liver function tests? And of course, bone mineral density. Do we do total body DEXA or just BMD? And as we wait for the results to come, do we start already on treatment? For example, do we start on a bisphosphonate taken orally, alendronate 70 milligrams taken once a week? And what about supplementation? Do you believe in this, or do you or your patients prefer dietary or natural sources? For example, calcium at 600 milligrams twice a day, or two glasses of milk every day. Or vitamin D, 400 IU twice a day, or do we go for sunlight exposure? And then, of course, it's convenient that they are combined. Do you go for the combination tablet? Which of them is better? The management of osteoporosis are guided by treatment options that we have to decide from the start. Do we want to prevent or minimize bone resorption? If that is so, then we choose bisphosphonates like alendronate. Or if our objective is to increase bone formation, then we go for the anabolic agents. Of course, the prerequisite management of osteoporosis dictates that we go through non-pharmacologic treatments such as weight management, weight-bearing exercises, and diet. Of course, fall prevention is important. And then we talk about calcium and vitamin D, vitamin D3 specifically. And if you're into it, other supplements. So how important is calcium? The calcium salts in bone provide for the structural integrity of the skeleton. We know that. And it has other important functions in terms of calcium and phosphate balance. But the little known functions of calcium, which are also important, include neuromuscular excitability and signal transduction in our nerves, blood coagulation, hormonal secretion, enzymatic regulation, cell-to-cell signaling, and neuron excitation for nerve function. For vitamin D, they have classical and non-classical functions. Classical, of course, are calcium and phosphate homeostasis, bone mineralization, and for the non-classical but also important functions, we have immune regulation, and this became very evident during the COVID-19 pandemic. Cellular proliferation, cellular differentiation, and anti-angiogenesis, and this has implications as far as calcium development or prevention is concerned. So what are the benefits of calcium supplementation? They, of course, have benefits for bone health, especially in postmenopausal women. In prospective cohort studies in China, Europe, and in postmenopausal women, they were able to show reduced mortality of about 30% and less of cardiovascular diseases and MI. The slight adjustments in lipid profiles were also seen. So we could see LDL lowering. And even in patients who were not osteoporotic or premenopausal, they found that there was a reduction of blood pressure and it lowered the risk of developing hypertension. So the significant reduction in the risk of preeclampsia became a very important finding as far as calcium supplementation was concerned, such that the WHO guidelines included a strong recommendation for pregnant women to take 1,200 to 1,500 milligrams of calcium a day. They also saw a reduced risk of colonic CA, as high as 46 to 50%, and colorectal CA from 30 to 37%. They wager that the mechanism involves the way calcium binds to the bile acids, which will result in less epithelial proliferation rate and therefore less adenoma formation. Another interesting idea about calcium use would be a reduced risk of kidney stones because calcium binds actively to oxalates. And this happens most obviously when you are during meal times. So the free calcium binds to the oxalates, and because of that, there's less absorption of the oxalates and therefore less stone formation. So vitamin D is a regulator of calcium and phosphate homeostasis, and because of that, a balanced bone metabolism will see an equivalence between bone resorption and bone formation. It affects cell proliferation, differentiation, and apoptosis via tissue vitamin D receptors. Apparently, all tissues, almost all tissues in our body have vitamin D receptors. And therefore, it's important in the prevention of cancers of the skin, breast, prostate, and colon. A severe deficiency of vitamin D, we all know, leads to rickets in children, osteomalacia in adults. And of course, secondary hyperparathyroidism, which will result in bone loss, an increased turnover rate, and eventually a low bone mineral density and your fragility fractures. Now, 50% of women with hip fractures have been seen to have low levels of vitamin D. And this is a classic study that has often been quoted that with that, you will have a 20% chance of mortality of the same patient within the same year, and that 50% of these patients will be permanently disabled. They also saw that 60%, or in another study, 89% of elderly patients with vertebral fractures were found to be vitamin D deficient. The treatment with vitamin D supplementation was proven to cause a 22% reduction in falls, and they found with high serum levels of vitamin D, there was a reduced risk of osteoporosis, falls, and therefore fragility fractures. Such that the National Institutes of Health Consensus Panel on Osteoporosis made the following conclusions: that adequate calcium and vitamin D intake are crucial to develop optimal peak bone mass and to preserve bone mass throughout life, and that factors that contribute to low calcium intakes include the inability or lack of access to dairy products, a generally low level of fruit and vegetable consumption, and a high intake of low calcium beverages such as sodas, which contain sodium, which actually negates calcium absorption. So this led to a plethora of guidelines for treatment where the recommended intakes of calcium varied from as low as 800 or 500 a day to as high as 1,200, sometimes even 1,500. But most of these guidelines revolved around 1,000 to 1,200 milligrams per day intake of calcium. Okay, so if you will look at the right side of the screen, of the slide, you will see that the red arrows are pointing to the volume or amounts of vitamin D supplementation that have to be added. Like for rapid correction, as high as 300,000 IUs of vitamin D3. And for those for elective correction, it would be from 800 to 2,000 IU. Later on, we will talk about whether this is safe to do or not. So the questions that we ask about osteoporosis are calcium and vitamin D deficiencies really still a major problem worldwide, especially in Asia, that this requires very aggressive treatment, as we showed earlier? Is the epidemic that we call osteoporosis and its burden on our healthcare delivery systems poised to become the new pandemic after COVID-19? And since for developing countries, LMIC stands for low to medium income countries like ours, the cost of ideal osteoporosis management is challenging. Is even the most basic and affordable but important treatment also suffering from a lack of attention. So if we focus on the more basic aspects of osteoporosis treatment, which are more cost-effective, will it be possible to at least decrease the burden of this disease? And how realistic is it actually to move forward towards prevention rather than intervention? So talking about deficiency, never enough calcium and vitamin D seen in the world. The estimate for world population as of 2020 is 7.8 billion people. And the estimated extent of calcium deficiency is seen at 3.5 billion, which is about 50%. Half of the world is calcium deficient. For vitamin D, judged at the level of serum level of less than 50 nanomoles per liter, in the USA, 18 to 30% of their population are deficient. In Africa, it's higher at 34.22. In Europe, even higher at 40% of their population. In Asia, it's more than half, 54%. In China, 72% of Chinese are deficient in vitamin D. In the Arab countries of Iran and Jordan, it's 90%. And in Southeast Asia, a little higher, 91% of Southeast Asians are deficient in vitamin D. That's a lot. So is osteoporosis, because of that, now suitably labeled as a pandemic rather than just an epidemic? You've seen this before. The burden of osteoporosis predicts that by 2050, we will have 4.5 million hip fractures a year. For Asia alone, 2 million hip fractures per year. The estimated number of people who are old in Asia is, well, age 60 and up, is expected to be by 2050, 25%, or 1 in every 4 patients. And the estimated number of the very old, meaning age of 80 and up, because survivorship will increase even in Asia, will be almost 1 out of 5 people. So by 2050, we expect that half of all hip fractures will be coming from Asia. And if you noticed earlier, Asia has more than half of the world's population. So the problem with that is the compliance for the need for surgery is only half. And we will have to work on that as orthopedic surgeons. So in spite of that, our patients come to us and ask, is calcium really safe to take because they read something in the internet? Is calcium essential? We know that the benefits of calcium will include not just evidence for bone health, but for hypertension, as we mentioned earlier, prevention of GI malignancies, and preeclampsia, as the WHO has mentioned, among other things. But calcium supplements were found to not increase bone density beyond a year after taking it. And this is very disturbing. Fracture risk is seen to be higher in countries where there is even greater consumption of dairy products, like the high-income countries of Western Europe and North America, more than in countries with low calcium intakes because of less access to dairy products like Asia and Africa. And this has become known as the calcium paradox. So calcium supplements taken alone was seen to even increase fracture risk. So even when combined with vitamin D, they did not find any evidence in community-dwelling patients that there was a benefit to it. Although, admittedly, in patients who are institutionalized in old folks' homes, it had a beneficial effect compared to those who lived with other families. Calcium intake has been associated also with serious complications such as severe constipation, urinary stones, myocardial infarctions, and stroke. Meta-analysis showed that hip fractures, there was no reduction in the risk of this occurring, and even an implied possible increased risk if patients were given calcium supplements. Another meta-analysis showed a 30% increase in cardiovascular problems, including MI. In prospective and RCTs in various years, there were gradually found increases in cardiovascular events, congestive heart failure, and myocardial infarction. Myocardial infarction. And the stated hypothesis here is that intake of calcium supplements causes an acute rise in serum calcium, which they claim accelerates cardiovascular calcification. So Adverse events are included in the GIT. I can imagine an elderly patient who will have to be admitted again and again to a hospital because of constipation, severe diarrhea, abdominal pain, flatulence, and bloating. And especially if they use supplements that are calcium carbonate based. And what about cancer? For colorectal adenoma, they found a relative risk of 1.13 positive, but that is not such a high uh, relative risk. So we put the question, is it risky or not? Now for kidney stone formation, we also found inconsistent literature. 17% or less than 1/5 patients had the risk of developing kidney stones. And they found out that the risk factors attached to this include abnormal urinary supersaturation, for example, if your patient is dehydrated, acidity, diet, and the health status of our patients. And if the calcium intake is in the form of oxalate, citrates, or carbonates, compared to if they took their calcium as milk or other dietary sources. The other implication is there might be a need to restrict foods that are rich in oxalates to prevent stone formation. And that would be your spinach, chocolate, tea, and others. And so what about vitamin D, which they said was the super vitamin of late? The beneficial effects are known not just for bone health as well, but also for maintaining balance, for fracture healing to occur, prevention of cancer, among other things. And in some studies, they found out that unfortunately vitamin D did not result in significant clinical increases in bone density, and significant complications of hypovitaminosis D was defined and known to us as stated before, less than or equal to 50 nanomoles per liter. Apparently, complications do not occur at this level, but at lower levels. So for patients who live with their families in the community, they were seen to be less at risk for fractures than those who were kept in old folks' homes or institutions, even if they took less vitamin D in their diet or as supplements. So high-dose vitamin D supplementation, we people are afraid, might even lead to greater risks of falls and fractures than what was previously thought. So is there an overuse problem here? So unlike calcium, the patient response or the body response to vitamin D supplementation depends on what the baseline level of their vitamin D is. A meta-analysis showed that vitamin D supplementation had no effect on the risk of total fractures or hip fractures, including those who were dwelling with their families in the community. The thresholds that they saw for this is not 50, but 30, or 12 if you're using nanograms per milliliter and not at 20. So at greater than 30 nanomoles per liter, they did find an only minimal effect on supplementation would be beneficial. If the serum level is less than or 30 nanomoles per liter and thus deficient, supplementation causes a substantial increase, correcting secondary hyperparathyroidism, normalizing serum calcium and phosphate, and reducing bone turnover rate. So let's take note of that. What is the normal value of vitamin D? If you notice, the values are fluctuating. But as of 2022, the National Institutes of Health, in their fact sheet says that levels of 50 nanomoles per liter or 20 nanograms per ml or higher are adequate for most people for bone and overall health. And that levels below 30 nanomoles per liter or 12 nanograms per ml are much too low and might weaken your bones, affect your health, and cause fractures. And for levels that are 125 nanomoles per liter or 50 nanograms per ml are too high and might cause health problems like increased number of falls and even fractures. So, is vitamin D harmful? They found out that for doses of 400 to 1,000 to even 2,000 IU per day, these are relatively safe. These are the maintenance doses that we give to our patients. But if you gave for somebody who is severely deficient, or you're trying to catch up with the deficiency at 4,000 IUs per day, or 60,000 IUs per month, or 300,000 to 500,000 IUs per year, you actually increase the risk of falls and fractures in your patients. So at 4,000 IU per day and 10,000 IU per day, they saw there was an acceleration of bone loss. So that's too much. So for cardiovascular disease and cancer, recent randomized controlled trials showed no benefit for prevention of these problems with vitamin D. And that muscle weakness in frail and elderly patients who happen to have frequent falls, they also found no benefit with vitamin D. They did see an improvement in the strength, especially, as I said earlier, if the levels of the patients are less deficient at less than 30 nanomoles per liter. But they did not observe any benefit for increase in the muscle power and mass. So higher dose supplements actually have deleterious effects on strength and muscle testing. And more interestingly, we found out that in a survey of orthopedic patients with the following diseases, they were found to have low vitamin D levels or hypovitaminosis D. So if you have the following cases, make sure you check their vitamin D levels and correct appropriately. We all know that for vertebral and other osteoporotic fractures, but even in non-union or close tibia fractures, delayed union of proximal humeral fractures, delayed union or poor osseointegration of surgically fixed fractures, in patients with osteoarthritis of the hip, knee, and shoulder, rotator cuff tears and tendinopathies, especially those that are hard to heal, and osteosarcoma and metastatic bone disease. They were found to have deficiencies of vitamin D. So we questioned the previous observations that were stated. In these patients where they said vitamin D and calcium were harmful, were the populations also studied into their subgroups such as the oldest old or greater than 75 or 80? Did the older groups manifest already large deficiencies in calcium and vitamin D that when you thus treat them, you will defer the feared complications seen in the oversupplemented, less elderly patients? Do these observations that were seen therefore merit an adjustment of treatment guidelines, such as the recommendations for the usual calcium and vitamin D supplements be shifted upwards to the oldest old groups only for ages greater than 70, and with more judicious use of calcium and vitamin D in our younger and less elderly patients, even if they are postmenopausal? What do we do? What can we do? Let's look at medical evidence. In the most recent ESEA meeting, where there was a consensus meeting, Des Dawson Hughes made the following conclusions with regard to vitamin D and calcium. Calcium alone has little effect on the risk of falls and fractures. This is based on the medical evidence that she was able to harness. A modest daily dose of vitamin D, meaning 700 to 1,000 IU per day, together with adequate calcium intake, reduces the risk of falls and fractures in deficient and insufficient older adults. Take note. Vitamin D supplementation in replete older adults, in other words, in those who have sufficient vitamin D levels, does not improve muscle performance, nor does it reduce the risk of falls. Supplementation to reach a level of greater than 40 nanograms per milliliter will appear to increase the risk of falls in older adults, so that is not a goal. And high bolus doses of vitamin D can also increase the risk of fractures. So in many parts of the world, vitamin D deficiency or insufficiency abounds, and there is therefore compelling evidence, as seen in the literature, that there is a need to meet calcium and vitamin D intake requirements in those areas, Asia, Africa, for example, and it will definitely lower the risk of falls and fractures. Older adults with vitamin D levels of less than 20 nanograms per ml will benefit from vitamin D supplements that will bring them into the range of 20 to 40. So try not to go beyond that. In those adults who are the range of 20 to 40 nanograms per ml already, do not give supplemental vitamin D. So supplementation of vitamin D resulting in levels greater than 40 will increase the risk of falling, as stated. So what's wrong with this picture? These are two laboratories locally that show the results of patients' serum vitamin D levels, and attached to it will be the reference ranges. What is wrong with them? These are what is wrong with them. The values that they use for normal or adequate. And we've seen what that can do. If you follow or use that as a goal or a target for giving supplementation, you get into trouble. So neither of them is desirable. So like I said earlier, that the latest NIH guidelines for vitamin D normal values are as stated. So what is enough? Enough of vitamin D, enough of calcium. We found out what is enough because we found out what is too much or over-supplementation. So supplementation with calcium alone for fracture reduction purposes is not supported by literature. So don't say drink your milk or drink your calcium because it will support you or keep you from getting a fracture. Calcium supplementation with concomitant vitamin D supplementation is supported for patients at high risk of calcium and vitamin D insufficiency. That's when it's needed. Then the safety and efficacy of anti-resorptive osteoporosis medications like bisphosphonates, or for that matter, alendronate, does not require the co-administration of supplements, interestingly, other than those patients who are with the need to treat for prevention of deficiency or already deficient or a clinical risk, therefore. Okay? So calcium and vitamin D insufficiency is still a major problem, especially Asia, Africa, but especially in Southeast Asia where we live. And these aggravate the epidemic or maybe pandemic that is osteoporosis and will burden our healthcare systems like COVID-19 did. And for low to medium income countries like ours, the cost of ideal treatment, which was set mainly by high income countries, is challenging, definitely. But even the most basic and affordable yet important treatment is sadly still inadequate where we are. So we need to focus on the more basic aspects of treatment for osteoporosis, which is more cost effective, including supplementation, because it will decrease the burden for our poor country. And perhaps it will be more realistic if we look towards prevention rather than intervention, or for orthopedic surgeons not to wait to treat patients after they get a fracture or secondary prevention, but even see patients for primary prevention. So at the end of the day, we need to reassure our patients, just like in our electorate just previously in the elections, that they need to discern the difference between fake news and what the truth is. Thank you for your kind attention. I'd like to take this opportunity to congratulate the Philippine Board of Orthopedics who is celebrating their golden anniversary this year, 50 years of excellent work in teaching the truth and the standards to our resident physician trainees. Congratulations.